at least if you are coming to a person, you are doing a cosmetic surgery, you are paying them well, you are, everything, you need to have at least a nice clean place. It should be according to the international standards. We have got the pulse oximeters. While you are being operated, there's a television, there is a DVDs and all those things, so you can watch whatever you want while we are doing it. This is my clinic in Islamabad. Now, patient selection. This person is not a good candidate. You can see his hair is very, very thin. And number two, somebody has still done so many surgeries, 1 cut, 2 cut, 3, 4, 5. So this is if you do not have a good candidate, which is type A and type B, which has got 200 hairs per square centimeters to 150, they are the best ones. This is where you would still see the base over here. If you can see the base over here, you will see the base definitely over there. So they can still get something done, but type B, they are not good candidates. We all learn the hard way as well. Now, the first, patient concern and expectations. All of you have got different expectations, different concerns. As a doctor, I will listen to each one of you individually. Try to grasp what is your main concerns. Now, my problem is donor area. As I said, my limitation is your donor area. You have got a wonderful donor area. I've got no limitations. Then how your hair loss pattern is, which determines if I see where is thinning happening, how young are you, that will determine me what can be done. And then if you are young in 20s or early 30s, I have to anticipate the future hair loss, right? If I don't do anything, leave anything for the future, it's only a matter of time. People will come back to me, hey doctor, look what you have done, blah blah blah. So I want to, if I'm a good doctor, I want to keep my reputation up, then I have to cater for anticipated hair loss as well. And then at the end of the day, it comes that whatever I do, does it look natural? Does it, well, people, if they are sitting just across the table, would you be able to see or do something? That is where I come in. Now, my problem is when I'm planning the procedure, I want to see this young man who is type 7 hair loss. He has got only limited donor area. Can I cover all these things? So I have to, what I do is that he comes to me and say he's from Saudi. He comes to me and say, look doctor, I've heard about you and I want my whole head to be done. Gradually I bring his expectations down, right? Because people will come, oh, I want to be the world's best surgeon, but gradually you bring him down and say that you want to be a good surgeon, and that can be achieved. Being the best surgeon of the world is not easy. Being a good surgeon is an easy thing. So I bring their expectations down to what I can achieve. I listen to what is patient concern and expectations. I listen and find out as much as I can about the goals, desires. Do the best you can to understand clearly all the aspects of feelings, wanting, here as all. So I listen to them. Then I tell them that, look, I can do something for you. Your looks can be changed. But I have to tell him that, look, my point of view, that you were type 7, you should understand there would be, redistributed in the bald area, should understand the hair loss is an ongoing process and so on, and you are younger, so I can only do certain aspect. And I give them that, look, I can give you a good look, but I can't cover everything. Now see how small, this is his donor area, and of this donor area, this small little area is the viable donor area. I can't take anything from there, I can't take anything from there. It is this thing which is now not there. That donor area is gone. Now see these fine hairs, they are little coarse. Do you know what happens over here? This is the medicine. That is where they help. Right? It might not be everything, but he is getting there. This baldness has improved. So overall, he's much happier. the most important, people all tend to give a lot of weightage to the front looks where we have done the hair transplant. What we do not understand is that if I want to really, somebody comes to me, hey doctor, the other doctor, Mr. X, has given him 7,000 grafts, give me 7,000 grafts. I want to compete him. I take a big chunk of piece and it doesn't close. You get a very bad scar. You get multiple scars. This is me. It's about 1.2 centimeters scar on this side and on that side. As soon as I can't cut my hair shorter than 2 inches because they will show. It's about a quarter of an inch scar I have, right? So these are the things the doctor, in spite of, I told him that, look, this is the thing you need to understand, things happen. But anyway, so if you want to do certain things, there is always a way of doing it. If you know that there is a black ice on the road, then you want to take care of that. There are two solutions. One is I do it in a vertical mobility. Dr. Myers do it in a horizontal mobility. What I do is I see how much hair I can take, how much hair he can. There are three things. Number one, how much is available? Let's say 5,000 grafts is available. Do I really need 5,000? No, I need 3,000. So I can take 3,000. If I need 5,000, yes. Can he give 5,000? Yes. Can he pay for 5,000? No. So I bring it down. So there are different factors where we end up to, and then we measure it. Then we see with the scale whether its mobility is there or not. If the mobility is there, then we can take and give you a scar which is about 1 millimeter to 2 millimeter wide, which is very acceptable and good scar. But the new technique is trichophatic scar closure, in which the visibility of the scar becomes even less. We do a special technique and then you can hardly see a scar. Even if I trim it down, you can hardly see. This is a scar. This is the scar. You can hardly see a scar. This is the scar, right? So even those people who want to trichophatic scar closure can give you a result. The problem with the trichophatic scar closure is that if I can take 1 centimeter, I'll take 0.8 centimeter, because 0.2 centimeters is there to give the sort of mobility. I don't want to make them close tighter, because that is how. So I end up losing a little bit of hair. So instead of giving you 5,000 grafts, I'll be able to give you 4,500. So something like that do happen. This is all trichophatic scar closure. You can hardly see a scar. I mean, he's number 1 trim. This is before the second surgery. I've just planned the upper line. I have to determine the lower line. My scar always comes within the next surgery. So you always end up in 1 scar only. You never have 2 scars. Now, follicular unit extraction. A lot of people are saying, oh, I want to do follicular. This is just one way of getting a graft. Right? In my opinion, I don't put a lot of stress on that. It gives me more money, but I don't like it. Number one, it's very painstaking for both me and the patient. Number two, it takes 5 days to do 2,500 grafts. On the other hand, it takes me 6 hours to do 3,000 grafts. Right? It's not value for money, except for those people who have got some special needs. Small surgeries, maybe for mustaches, do only 800. Why to give a scar? Just take a small little area, take about 100 grafts and do that. You can see 2 roots, 2 here, 3 roots, 2 here, and 3 roots, 1. So this is about 1 millimeter punch. Right? This is how we take. This is how we, these are I do, let's say, 1 session over here, 2nd session here, 3rd session here. So it will be about 600, 600, 600, about 1,800 grafts. And then we will do in between another 500, 600. So this is how we do punch. And these punch, because they are millimeter, they will heal without leaving a trace. Right. Anticipated future hair loss, very important. A patient who is 25 and has class 2 or class 3, he can go to class 7 in 10 years time. So if I am not careful and I try to take a donor area which would fall off, all those hair which I've taken from there will fall off.